Good morning, good afternoon, good evening, depending on where you are, and welcome to this session today on lessons from the COVID-19 response, the importance of using community-based data in emergency response. My name is Manisha Thomas, and it's my pleasure to be facilitating today. And we're really excited for you to be joining us on this fourth and final of 4 webinars that we've organized that's been organized by the Interagency Standing Committee in collaboration with PHAP on accountability to affected populations during the Humanitarian Networks and Partnerships Weeks. Before I start introducing our panelists, let me just talk a little bit about, as I mentioned, this is our fourth and final of 4 sessions organized by the Interagency Standing Committee in collaboration with PHAP during the Humanitarian Networks and Partnership Weeks on accountability. 4th session on accountability to affected populations during the Humanitarian Networks and Partnerships Weeks. Not that the whole HNPW was about AAP, but really these sessions have been great in terms of raising lots of really interesting examples and questions. And they've been building on a number of conversations that we had back in the latter half of 2021 on accountability to affected populations. And it's been a really great sort of series of events leading up to today, the final one, around really trying to identify what are some of the challenges and what are some of what's some of the progress we've made on accountability to affected populations. So just to kind of let you know what the previous ones were. The first one that we had during the Humanitarian Networks and Partnerships Week was on towards collective accountability to affected populations approaches at country level. That was our first one. The second event was on a standardized approach to complaints and feedback mechanisms. The third one, which we had last week in person, which was quite exciting, was on accountability to affected populations, a leadership commitment. And so today's session is really looking at the importance of using community-based data in emergency response. And it'll be great to sort of see what you all thought about how community-based community engagement was used and carried out during COVID-19. And we'll come back to what you're saying in the Mentimeter shortly. But today we're really going to be talking about the experience of the collective service. And the collective service is a collaborative partnership between UNICEF, WHO, the World Health Organization, IFRC, the International Federation of Red Cross and Red Crescent Societies, with support from the Global Outbreak Alert and Response Network, or GORN. I'm trying to say everything out because in the last session, we had a big conversation around, we have too many acronyms around accountability to affected populations. So I am doing my best to not trying my best not to use too many acronyms. So the collective service really aims to deliver the structures and mechanisms that you need for a coordinated community-centered approach that's embedded across public health, humanitarian, and development response efforts. Therefore, it can ensure more expert-driven, collaborative, consistent, and localized community engagement support that can reach governments and partners involved in the national response, particularly to COVID-19. And so today we're going to be really talking about some of the examples from the experience of the collective service around how a collective approach to community engagement and coordination around that can make a difference in the response for communities that are facing multiple threats and where the same partners are responding simultaneously to a public health, humanitarian, or other emergencies. We're going to really hear about some of the experiences today about how social data has contributed or not to informing and shaping responses to epidemics, with a focus on the response to COVID-19, but also Ebola, and emphasizing some of the lessons that we can learn that will hopefully benefit humanitarian responses in the future. We're also going to hear from our panelists today about how investments in data systems can contribute to more effective preparedness programming, which can strengthen community resilience through better preparation, response, and learning. We'll hear some really good concrete examples, which will hopefully inspire you for those across the spectrum of humanitarian and public health crisis responders on the benefit of collective approaches to community engagement and how they can contribute to faster, more accountable, and more effective responses. So we've got a great panel today who's going to give us lots of examples and lessons. So it's my pleasure to really welcome all of our panelists. And let me introduce them. They're going to be talking about their own operational context and how community source data has been used in terms of making responses more accountable and effective. Our first panelist is Sylvia Magnoni, who is the Global Coordinator for the Collective Service for Risk Communication and Community Engagement, or RCCE. We've also got Gibstar Makangila, who is the Executive Director of Circle of Hope. We have Joran Reimanants, who's a medical MD, PhD research in Leuven in Belgium. Sorry, I was like, wait, where's Leuven? It's in Belgium. I think that's correct, isn't it? Yes, good. Sorry. We've got Simone Carter, who is the lead for Integrated Outbreak Analytics, or IOA, and also a UNICEF Public Health Emergencies Manager, and in UNICEF's Public Health and Emergencies. And she's also the manager of the Cellule d'Analyse Intégrée, so the Cell for Integrated Analysis in Congo, the Democratic Republic of Congo. We've also got Umbretta Baggio, who is the Community Engagement and Accountability Senior Advisor in the International Federation of Red Cross and Red Crescent Societies, the IFRC, and Community and Engagement and Accountability may sometimes be referred to as CEA, although we're trying to move away from those acronyms. And last but definitely not least, we've got Ngoni Niambawaro, who is the Interagency Country Support Officer, Eastern and Southern Africa, for the Collective Service for Risk Communication and Community Engagement. So before we turn to the panel, I want to make sure that we definitely want to hear your questions, either through the chat, your comments or questions, but also, as Marcus said, we've got the Q&A option as well. So you can put your questions there, and you can also post those anonymously if you want. Before we turn to the panelists, let me just briefly look at the Mentimeter that you've all contributed to about the overall view that you have about how community engagement was carried out or during the COVID-19 response by humanitarian actors. And I'm seeing a lot of challenging, insufficient, uncoordinated, lacking coordination, insufficient, challenging barriers. Somebody wrote using SBCC, and I have no idea what SBCC is. I'm so sorry. So if whoever put that in could tell me what SBCC is in that acronym soup that we have. Thank you, social behavior change. But then like I feel that there's a lot of challenges there. I'm trying to look for some more serving vulnerable ones, I think is a more positive side. Strong at the start, which is an interesting one to see that things changed as it went along. Monodirectional, and I think that'll be a really important one as we look at the examples we have today, is sort of like how do we make that more of a back and forwards, not just taking information, but also feeding back to the communities we're working with. A form of domination, restricted, fair, distribute, easy reading, not usefully, challenging, serving the vulnerable. So there's that as well. I think it really does highlight that, engaging communities is not always going to be an easy task. And yet, if we do it, there's a lot of benefits to it in terms of how our responses can be better and more effective. So we're going to launch the second Menti question, which we'll leave up for a while the speakers are talking, so you've got time to respond to it. And here it's a question of how much do you agree with the following statement? So to what degree do you feel that risk communication and community engagement, or RCCE, during the COVID response has led to important innovations in community engagement and accountability? The second question is, risk communication and community engagement mainly applies to health, so has limited relevance for accountability overall in humanitarian response. And the third question, as to whether you agree or disagree, humanitarian response in general has important lessons to learn from risk communication and community engagement regarding accountability. And I see that some of you are answering those already. And I see that there's lots of agreement and some disagreement on the second one, but we'll leave that up there for a while for all of you to be able to answer. So with that, before we start looking at some of the examples that we're going to hear from our panelists, I'm going to turn to you, Sylvia, first. Mm-hmm. So for those of us who don't really know what the collective service is beyond that short description I provided, tell us what it is, and in an elevator pitch style for those of us who are non-specialists like me, what is the collective service?
Thank you so much, Manisha. Thank you for all our speakers and participants today. So, Manisha, as you rightly said at the beginning and in the introductions, the collective service was born in 2020 out of COVID, right? As a partnership between different partners who wanted to come together to increase the scale and to increase the quality of community engagement approaches. Really, at the time, I think we all agree, when due to COVID, there was a need to accelerate community engagement support for governments and partners who were heavily involved in the national response. And as a collective service, there was a firm belief of the fact that this type of community engagement support needed not just to be to any type of support, but support that was collaborative, that was localized, that was evidence-based, and we will be talking about that today on the importance on grounding action on community-based data. A type of support that is fundamentally expert-driven, so you can get the most out of community engagement activities. And so that has been the work of the collective service for the past 2 years. We really have worked to provide this practical support to those who were delivering on the ground. And we've done so by leveraging all of the complementary strengths of our partners. We like to say that we've taken out the best of what all our partners organizations could offer in terms of expertise in the community engagement space. And we made this expertise available to actors and governments on the ground in the form of specific services, whether they were capacity building services, technical assistance and support, coordination structures, and so on. Particularly, a lot of our work, and we will discuss in today's session, has been on strengthening evidence generation efforts carried out at global, at regional, and country level. So really supporting actors on the ground with the type of social data that was needed to inform their response. And we have supported these efforts in very fundamental ways, really providing a series of products, providing a series of tools that have enhanced the partner's ability to listen to communicate, to engage with communities. So we're talking here about tools like dashboards to track and monitor social behavioral data, or support for joint community feedback mechanisms, social listening and infodemic tools, and so on. So on the one hand, there was, and there is still a firm belief of the role that community source and community-based data needs to play in responding to emergencies and humanitarian crises. But on the other hand, there's also a lot of expertise, a lot of lessons that the collective service has accumulated over the past 2 years. And that is why we also wanted to bring that experience in today's session, and particularly to highlight this experience on how to use social data and how to use community-based data in emergency response, and how this conversation can really benefit also actors involved in other humanitarian responses in the future.
Super. Thanks so much, Sylvia. And so why is the collective service so critical to ensuring we're accountable to affected populations? And how does it fit into all those other initiatives that we have around accountability to affected populations? I mean, in the last session that we had last week, there's lots of things going on. Have we overcomplicated it? Or how does the collective service really fit into that overall accountability puzzle that we've got?
Thank you, Manisha. I think there's a lot to think here about also the name that we have, but also the concept that we're promoting, which is a collective approach, which speaks to the survey that we've seen before in terms of what were some of the challenges that we've seen during COVID when engaging with communities. And a lot of that was about lack of coordination, lack of joint efforts. And so I'm trying to answer your question also on the reverse. I mean, what would have happened if we didn't have a collective approach to community engagement during the COVID emergency? I don't think we need to go that far with memory or with imagination to think about public health emergencies and responses where, that collective working or that collective approach wasn't there. And the lack of this collective way of working, we know that comes with consequences and repercussions in terms of timeliness and efficiency and quality of the response, and also the way communities are engaged in it. And I feel that is, in a way, also the role that the collective service has been played in this past 2 years to really strengthen the collective approach, to support functioning coordination mechanisms on the ground, and to do it in a way that really puts communities and their fears and their perceptions and their concerns at the heart of the response. And I feel this is where really what we think is the biggest innovation of the collective service comes into place, the global behavioral dashboard. At a time, and I'm going to put actually the link in the chat in a moment, but for those of you who don't know the global behavioral dashboard of the collective service, this is the first of its kind repository of social and behavioral data for COVID-19. It covers almost all countries out there. It collates information coming from more than 400 multiple different data sources, and it aims really to track fundamental information about knowledge, perceptions, practices, fears on the ground by communities and for communities. And at a time when really, at the beginning of COVID, if we think about that, coordination and collaboration in social data collection and analysis was severely lacking. So the collective service with the dashboard came and filled this gap and facilitated collective action through a first of its kind of the repository that makes community-based data available to all. And it's a tool that comes out of two fundamental commitments, I think, of the collective service. One, it's a commitment to ensure that critical social and behavioral information is available equitably to all levels and to all countries. But particularly, it also comes out of a firm commitment and conviction of the collective service and its partners that using this data during the responses almost an imperative, is really a critical part of how we want to engage and how we want to communicate with communities, and ultimately also how we want to be accountable to them.
Thanks very much, Sylvia. And I know that we'll hear a bit more because there was a question that came up in terms of, I'm trying to find it. What are some of the, can we get to the keys in terms of how data is generated, who's collating it and using the data? Since there's a sense from what you said, Sylvia, that there's a disjoint between who's included in the data, who has the knowledge and skills to draw out the information from the data. But I think we'll hear about that from our panelists. So unless you wanted to add something there, Sylvia, now.
I think given on the table, we do have panelists that really can bring some of these perspectives into life, I believe. But very good question, and look forward to engage in this discussion today.
Super. Thanks so much, Sylvia.
Thank you, Manisha.
Before I turn to our second panelist, I want to just take a look quickly at the Menti poll to see sort of what degree you all agreed with the statements around risk communication and community engagement during COVID. Sort of a mixed bag of, general agreement, I guess, that we had some important innovations in community engagement and accountability. Definitely less agreement around, more disagreements around the fact that risk communication and community engagement mainly applies to health. So it's great that everyone most people see that there's a link between risk communication and community engagement. It's really long. I understand why you've got acronyms. It takes a long time to say all the words out loud. I'm going to say it RCCE just to save some time, that there are obviously implications for us in accountability in humanitarian responses. So that's great. And really strong agreement there in terms of humanitarian response generally has important lessons to learn from RCCE around accountability. So great to see those views, and we will be looking a little bit more at those. Let me then turn to our last and final Menti question before I turn to our next panelist. And this one is, what main lesson would you highlight from community engagement around COVID-19 for accountability of humanitarian responses in general? And there you can just provide your written answers, and we'll leave that up and we'll come back to it later on today, or in the session, sorry, not later today. I'm next going to turn to Gibstar. And Gibstar, you're the executive director of the Circle of Hope, and you're going to be giving us some specific examples of how community-based data is used in programming, specifically in Zambia. And Circle of Hope has been engaging in the fight against HIV and more recently in the COVID response. And engaging with communities has been really central to your work. So in your experience, how have communities been wanting to engage in the response?
Thank you so much, Manisha, and a very good morning to our participants and also to my colleagues, the panelists. Firstly, just to share a few of our experiences in regard to how we have used data to check the costs for community engagement. I have drawn about 8 quick nuggets of some of our experiences and findings. Number one, we've realized that community engagement in terms of responding to any pandemic, for that matter, must be done early, and the community structures must be involved from program design through to implementation and up to feedback and also evaluation. Now, this is important because we found out that there's a lot of wisdom inherent in these communities. And part of that wisdom is arising from the fact that they have intricate knowledge of the behavior of community members. And some of those behaviors could actually be exacerbating the impact of that particular response or rather pandemic in that community. And so we've learned that early involvement across the life cycle of the response is very, very important. Secondly, we've also learned, Manisha, the fact that collaboration at community level also does experience collaboration fatigue. And so this is because as respondents or practitioners in the response, we sometimes forget that we need to encourage these community players, especially the community influencers, with little things like incentives to cover their talk time, to cover their transport costs, to cover their missed lunch allowances. So many of our programming are focused on our budget as practitioners. But really we need to put in a small amount to ensure that the key gatekeepers of those communities are incentivized even in non-monetary terms. For instance, tools such as identification tags, caps, t-shirts, water, and anything like fuel to ensure that the dissemination of the message we're trying to convey is done. Further, we've also picked out something that has been a recurring theme, that we need to listen to the community. I think that we do more talking and instructing than listening. The feedback must be timely and action. And so listening will mean we change the course of our design midstream. We don't have to wait for the end of the intervention for us to change course. Number 4, the issue of decentralizing the response to really community level. What we've done in HIV and COVID, we have what we call community posts. These are single rooms found in markets. Currently in the city of Lusaka, we have about 65, 40 for Circle of Hope and another 20 for our partners. These have been the nerve center of the response. Let me give you one example quickly, Manisha. In the city of Lusaka, we have about 13 non-Ministry of Health organizations participating in disseminating COVID-19 vaccine messages. Of the 13, Circle of Hope alone is contributing about 80% of all vaccinations. The other 12 who are not engaged in the community approach, the one I'm discussing now, are only contributing 20 to 25%. And this is because of the approach of community engagement. And secondly, after we decentralize this pandemic to the very small level of community, we also need to increase the access points. And so the more testing centers, the more vaccination centers we have, the better. This is going to help our communities to cut down on the cost of access, congestion, and the time it takes for them to be served. For instance, in the case of HIV testing and in the case of COVID-19 vaccinations. So replicating as many smaller units nearer to where communities live, work, and socialize is going to assist in the fight. And the other thing is the location. Where do we locate these intervention points? We really have to locate them not where we want, but where the community desires. And so again, the issue of listening comes in, where in choosing the location, we involve the community influencers. These include the faith community, the local leadership, counselors, and so on. Further, a big one for most of us engaged in humanitarian efforts is the issue of customer care. Sometimes we deal with numbers and forget that we're dealing with actual human beings. So we need to introduce a humane side of approach that embraces empathy, compassion, and indeed passion in our work. Let the community feel our heartbeat, that we're not interested only in their numbers, for us to be able to report to our donors or report to our funders, but really we have to be accountable first to the recipients of our intervention. Number two, to the government. Number three, to our financials. Lastly, but not least on that question, is the issue of us accepting that we do not know everything. We need to relearn the issue of intellectual humility by recognizing that communities indeed are the first responders of any pandemic, because in them there's an inherent ability to survive. They want to survive that pandemic, and so we need to give them that platform and that ear for them to know that we have something to learn from them. They live in those communities, they experience the impacts of that pandemic, and so this is my introduction, that together with communities, in a true sense, we will succeed in any pandemic if we involve them and using the data that is coming from them. Thank you, Manisha, for that first question.
Thanks very much, Gibstar. And I'm going to ask a little bit more kind of how you've been using that community-based data. And you mentioned also that you're going to change the course of your programming based on the feedback you get. And that point, I think, about really making sure that we're not just extracting information from people, but we're really there for, we're getting that information from them for a reason. So is there something that you potentially need to do better to leverage data for accountability? But I'd love you to talk a little bit, because, you know, we talk about communities as community as a big term, and yet we know that they're not homogenous, right? We know that in every community, a leader may not necessarily be representing the views of everyone across. You know, there may be discrimination inherent in a community. There may be gender discrimination, ethnicity, caste, based on a question from Leslie from India, you know, caste, race, age, ability, disabilities, you know, how do you make sure that you're getting the views of the diverse individuals in a community so that you're able to shape and correct programming? And then, yeah, how do you need to do something to leverage data better?
Thank you so much, Manisha. Firstly, what we have done is we have a small tool that we developed as a direct response to the data coming from the community. And that small tool, we call it the DROP-I, as an acronym for DRQPI, and it stands for Data Review, Quality, Performance Improvement. So what's been happening in our sector, generally, we do review the data, and we also reflect and assess the performance. But what we haven't been doing consistently is to formulate strategies arising from the data review. And so our acronym approach is that we have daily data review, weekly data review of every single data. So we break down the data to the smallest unit, be it by section of a particular community, family by family, so that the second question you asked in relation to how we ensure that every segment of the community is served, we actually use the data by breaking down and disaggregating the data to the smallest package of data. That has to do with, of course, the age, the sex, the tribe, the persuasion, the gender, of course, and of course the religion as well, so that our response to the data review must be informed to the smallest unit. And so the DROP-I, that is the data review, must be seen as a means to an end and not an end in itself. So in using data, not only must it inform what must be done, but it must also, using the passion and the empathy, enable us to innovate So I noticed the question, the first question you asked, how innovative were we globally in the response to COVID-19? I think that we were innovative, especially in Africa, because of the scarcity of resources and scarcity of information as well from the outset. So innovation must come out from our desire to serve with empathy, compassion, and indeed passion. And so that's the first thing we do in terms of data. The second thing is our engagement is designed by another strategy we call responsive technical assistance. We no longer believe in routine technical assistance in any intervention, but it has to be responsive based on the strategies arising from the drop-eye tool. And lastly, a big one, Manisha, is what we call the reverse mapping. Once the data comes from the community, broken down to the smallest units, we now engage in planning that is using the trains based on surveillance, be it COVID. And so we now reverse map our innovative strategies based on the data. And so this has worked wonders for us. For instance, in the area of HIV, in 18 months, we have seen over 1,500% increment in case identification, meaning that for a particular facility under Circle of Hope, which had 3,500 citizens in Lusaka accessing HIV, in 18 months, using what I've said, we are now at 33,000 of them in 18 months. Same city, same members of staff, same funding levels, but increment of over 1,500%. And so this is what we've done in the last 18 months. And when COVID came in, we found that the barriers to accessing HIV were the same barriers to accessing COVID. These were stigma, cost, time, poor customer care, and a lack of sectorial collaboration. Thank you, Manisha.
Thanks very much, Gibstar. And I'm sure we'll come back to you when we have the Q&A to get some more examples. But I think that fact that you're really looking at, the smallest data sets to be able to influence and change the programming is really critical. And I think gathering all that data is probably a huge amount of work, but then you have great results because you're using the data to then, as you said, sort of reverse map what you're doing and making improvements as you go. So thank you very much for that. I'm just going to remind everyone to please make sure that you respond to our Menti questions, the last one around what the main lessons are from community engagement, and we'll come back to that briefly. There we see some of these, hang on, I have to make my screen bigger to be able to see that. 1 second, my eyes are not that good. Hey, 1 second, sorry. There we've got some examples of, more coordinated support across sectors, strengthening engagement by key influencers, community leaders, more capacity in communities than we normally expect. So really not a single community engagement. They're not homogenous. I think that point that I also just raised with you, Gibstar. Most valuable people, how we need treatment for COVID-19 for free. A common approach was on accepting lockdown and related by laws. So we'll come back to those, but I do encourage you to respond to that question and we'll revisit it after we hear a bit more from our speakers. So thanks again, Gibstar, for giving us those examples from Zambia and looking at the work around HIV and then COVID. We're now going to take a move to Europe to hear from Joran, which is a very different kind of example of community engagement, but one that's illustrative of some of the core concepts of using community engagement and data to build trust in communities, and in turn to actually have stronger programming. So Joran, I mean, you've been working with a lot of students there, but can you tell us briefly about the program that you were running among students in Leuven in Belgium? And could you highlight how the data and community information was used to improve contact tracing and build trust during COVID-19?
Yes, thanks and thanks for having me. So indeed, I was the medical responsible for a testing and tracing program set up by the University of Leuven for its 50,000 tertiary education students. from October 2020 onwards. And from the outset, we saw the need for accurate and structured data to improve our service, to improve surveillance, and for academic research. But we also saw the need of the help of the community to gather this data, because we couldn't do it at scale to do these assessments. And I think several things of our data collection system are highly transferable to other settings in public health and beyond. And I think those are interesting to relate on. The first is to try and bring forward and decentralize your data collection. In our specific example, we had students who decided they needed a test and booked one to already share some of the data themselves. For example, on vaccination status, on symptom onset in an online module. When they then came to the testing center, additional data was collected, which was relevant to the contact tracing afterwards, and which allowed to already give some advice on the risk of this individual and their immediate environment. So the second aspect is to have peers collect the data. In our specific example, students manned the testing center, students did the contact tracing, and students often went to student residences to give advice on preventive measures. And this obviously generates a peer-to-peer trust bond. The third aspect, which Gibstar also alluded to, is to always link data collection to service delivery. Me as a clinician, I'm used to patients sharing their data because they believe that then I can make a better assessment and provide proper treatment. We had the same view on contact tracing. It's basically a health intervention. So whenever you are able to provide better assessments based on the data you get this trust. So the obviously there's many examples of how this improved contact tracing. We've worked on risk factors for transmission in student residences, on backward contact tracing, testing indications, some of which changed national guidelines or made it to the WHO contact tracing guidelines. But how we fed back to the community and how this generated trust, I think there's three aspects. The most important one is the fact that now probably 1,000 students worked in our program over time, and they became our ambassadors. When they saw the language, the knowledge we generated and how we did things, they became ambassadors on how do you assess transmission risk and what is the science about COVID transmission currently, and they translated it to their social circle. We also had the university spreading information and changing their guidelines according to the data we generated. And what was also important, a couple of times we came in the national media and students saw that, and this generated trust also.
Sorry. It's amazing that, you were able to get them to really sort of take it on themselves and then become ambassadors. I mean, I had seen a question sort of, how do you kind of encourage people to do it? And I think Gibstar also raised that point about those incentives. So like with the students, were there particular incentives built in, or was it just that, oh, you're going to get more social media followers and you can become more of an influencer or something like that? Or were there like incentives built in the way that you did that to get them on board?
So students who worked for us, they were being paid as student workers. So they had a financial incentive, but also we tried to build this atmosphere of we can do this together, and we're part of the positive response. And one specific example of how we went very far in that is that students who broke the law, broke COVID rules, were referred to our system to do a kind of internship and learn how important the response was, how it worked. And then they also became our ambassadors of, okay, these guys they know what they're doing, and now I know why they're doing it.
Yeah, interesting. So data sharing is obviously needed for contact tracing, but in the COVID response, this also sparked debates about data usage and retention. I think it's a conversation we often have in humanitarian responses. It's my data, I can't share it, GDPR rules, and I don't know what that stands for. I never know. It's the data protection, European Union law around data protection, and is often used as sort of we can't share our data because of the GDPR rules. I should know that acronym by now, but I'm not a data person, so I stay away from that. But how did your program approach that whole issue of data privacy and security concerns in the communities, which others, so that others can learn from that?
This is a European perspective. So we have strict privacy laws, but also a Belgian perspective. We have a very broad definition of what is clinical academic research. And so from the outset of our program, we had to very clearly define what data points we wanted to gather, why we would gather them, and discuss this with a data protection officer who was responsible for GDPR within the university, to have legal backing for our system. But we also went through the same process with the ethics committee, where we set up academic hypotheses, and they agreed then for us to gather certain types of data. This is a matter of due diligence. It allows you to be very specific on what you do and why you do it. But then you can communicate this due diligence to your end user. But then these are the formal aspects. And then in practice, and Gibbs also alluded to this, we were always very adamant that service delivery was at the basis. For example, when a individual didn't want to share their contacts with us, we were fine, we were cool with it. And we said, you don't need to, but please, can you give this and this advice to these contacts? Similarly, if a homeowner said, I don't want you to know who lives in this hallway of the student residence, we said, fine, but can you please refer these people for testing? And that's it. So service delivery was always at the basis. The accuracy of the data came second.
Thanks very much, Jeroen. And I think that way that you've done it, really thinking about what are the questions you ask and going through the General Data Protection Regulation Officer. Thank you, Sylvia, for putting that in there for me. And then really also the ethics committee. And I think, really having that reflection and making sure that you've got that sort of due diligence in advance is super important. And the way that you managed to get around, if people didn't want to answer, you still could provide the information, which is great. There's a few questions around data protection and use was really an issue during COVID and after COVID. And here's a question from Chris about, what happens to the data afterwards, especially in South Korea, where data stressing, I don't actually know what data stressing is, was very prominent, but what happens to all that data that you have?
So there are guidelines on what we can do with it. So it needs to be pseudonymized and stored. And then according to our ethics approval, we can use it for further academic research according to the laws, which is, you can use it for several years afterwards in a certain form. But there are guidelines on you having to encrypt it, having it to be in servers which are protected. We know who accesses the data and why. These people have to sign papers saying they will only use it for contact tracing. So we know who accesses the data and why, and it's according to both the regulations and the ethics approval.
Super. Thanks very much, Jeroen. And I'm sure there's going to be more questions coming up. And Vicky noted the aspect of using peers to collect data is an aspect to consider as it is effective. So thank you for that. And I know that there was a question around what techniques are being used while ensuring community engagements and data collections, but we're going to come back to that one because I think some of our other speakers will be speaking to that. So thanks very much, Jeroen. I'm going to turn to you, Simone, and, looking at the Ebola response in Congo, which was then further complicated by the COVID response, the integrated outbreak analytics that you're part of, what is the approach that the integrated outbreak analytics, what is that, and how is it concretely supporting local health actors when there is an outbreak?
Thanks. So integrated outbreak analytics is, it's an approach, it's a way of working, but it's something that was really actually, that we set up quite organically. So we gave it a name after we've been doing it since 2018. And so the idea is really in the 10th Ebola outbreak, we tend to, in outbreaks in general, we tend to be really focused on surveillance data. And then you have, anthropologists working in community data, and everything's a bit separate. And the idea of IOA was bringing together all the different data sources, data actors, not criticizing, putting down, or owning each actor or individual owning the data, but sitting together under Ministry of Health leadership and saying, what are the questions and information we need to understand outbreak dynamics, to understand the impacts of the outbreak on communities and on community health, including the impacts of the response interventions. And deciding on the questions together, deciding on methods and data sources that were required to answer the questions, collecting that data locally, analyzing it locally, and using it locally in an operational way. And so data sources vary from program information, or program data, health information systems, so DHIS2 or other health data, surveillance data, then also community and community source data, but also looking at things in the context of political events and gender and social norms, but doing this all like collaboratively. So we're sitting in a room together, different specialists, different organizations, nobody wearing their logos, nobody owning it, everybody recognizing that actually data is provided by communities. It belongs to them, and it belongs to the Ministry of Health to be making those decisions. It's not about getting our PhDs in the middle of an outbreak. And so really pushing that kind of agenda forward. And so it's also not about collecting new data. It's about recognizing that if data does exist, use what's there, and work on that collaboratively to make near real-time decisions as operationally as possible.
Interesting. And I like that, the no branding, and that, at that point around, it's the community's data that you're using. So we shouldn't be owning it as organizations, I think is really critical. Can you tell us a little bit, why is community source data so important, and what are some of the challenges and opportunities of using integrated community data?
The community source data can really tell us, why a particular group or a particular place or a particular disease at a particular time. It can also tell us what approaches may or may not work and why. So it kind of complements, we can see a disease happen in a particular way or in a particular group, but we can't always understand why unless we're looking at that community source data, or why one intervention works in one area and not another. I think one of the reasons why it's often not well used, or why we face challenges, is because we're doing it in a silo. So again, we're not agreeing on a methodology or data collection tools that are developed with the users of the data. So again, the approach by IOA is you identify the questions, the information that you need, but you agree on a methodology, you agree on the questions, so that you already have the user in mind. You already have the decision makers in mind. You are using a method that feels rigorous enough, or has been agreed on by everybody to be able to really use that data. In outbreaks, outbreaks are often led by epidemiologists and medical doctors, and we like statistics and we like big numbers, and it's about coming to ways of, but if we involve people from the beginning, if we're really working with the data users from the onset, community source data can be super usable. And if we're integrating it with other data sources, and we can show relationships between community source data and health information systems. So, when we see spikes in healthcare services use or drops in particular vaccination rates, or engagement with particular response interventions or prevention mechanisms, and we can explain those, and we can see how the use of that evidence informs outbreak response, it gets better used. But it's also, again, about working together, as opposed to saying, I'm going to go do my study and collect it in my corner, but really bringing together those different actors in an outbreak.
Thanks very much, Simone. And at that point about really thinking about the data, the end users, and keeping them in mind, and really identifying how you're asking those questions, I think is critical, because in the session we had last week, it was one of those things is, there's all this information that's gathered, but sometimes it's not in a digestible form for decision makers. So that point, really about thinking about the end users, how do you make it clear what all that huge amount of data translates to for those who need to make decisions in an easy way, given they have all sorts of other priorities as well, I think is really critical. So what can we learn from how the integrated outbreak analytics, IOA, supports responders in Congo, but also, where you've got different crises and public health emergencies? What can we learn for humanitarian responses elsewhere from what you're doing?
Yeah, so IOA in the last 4 years, we've been setting up this capacity within the Ministry of Health. So it can work in multiple ways. We've supported other countries and programs. It's about being context, country, community, actor specific. It's about being flexible. It's not about having fixed rules or tools. It's about supporting what works in the context. So right now I'm in Ecuador for an Ebola outbreak again. And here we have a cell. So we have different actors. There's 7, 8 different organizations who sit under the Ministry of Health. We have daily meetings to look at, real outbreak dynamics in real time. But when we're looking at things like measles or malaria or the plague here, that might be an IOA approach, but less of a cell daily meeting. So you go to the location where you have the disease, and we work with local health actors, bringing together all the different data sources, agreeing on how data will be used, running analysis, and like co-developing recommendations on location in real time, not publishing a big report first, co-developing action. But so it can be in a cell form, it can be for a particular disease or at a particular location. IOA can also be used for early warning. So we tend to have early warning systems that are, SMS if we've seen a disease, but we can use health information systems, we can use community data, we can use all kinds of other data to provide other sources of early warning to help ministries of health prevent or respond earlier to disease. We can use them in rapid response teams to better evaluate and understand outbreak dynamics in a new disease as well. So it's really about working with Minister of Health, saying, what are your health needs in a country? What are your health concerns? How can you use all the data that is available for you? How can you better own the data that NGOs and UN and all the partners are collecting in your country and support your country to better use that with the Minister of Health? I think there's three main principles so that do remain consistent. So one is about capacity building. So data collection methods are often owned or data analytics methods are often owned in Western or high income countries. And so how do we make sure that all of that capacity is consistently transferred? And in an outbreak, we often don't have time. So we do like a half an hour training 1 day a week, and we assume that builds capacity. And it's about actually strengthening capacity. So that's long-term investment, that's consistent accompaniment. And that's sticking it out for more than one outbreak at a time to make sure that capacity is built. So for example, this is the fifth Ebola outbreak that I've been here in the DRC in the last 4 years. And, the outbreak starts with the Minister of Health who come and bring all of the other integrated outbreak analytics studies and results. And we start the development of the plan with that evidence, but it's not brought by anybody but the Minister of Health. The second is, again, about it being a multi-actor, multi-data, no logos, no branding, no ego. So if somebody else already collected the data, you need to be ready to not collect it. You need to be ready to use the other person's data or the other organization's data. Databases, surveillance bases, contact tracing bases, those belong to Ministry of Health. They don't belong to the World Health Organization or any other international organization. And so stepping away from insisting on our own studies, stepping away from owning that data and really facilitating country ownership. And finally, it's about monitoring the use of evidence. So we set up really simple ways to co-develop. So again, data is collected, analyzed, and used in real time in whatever community context outbreak. So we don't collect and then walk away to analyze and walk away to co-develop. We collect, we present, we co-develop with local health actors, with civil society, with NGOs, with Ministry of Health, anybody who's there, presenting data in multiple ways, multiple languages by different people, so that we can co-develop evidence-based action and track that over time. So it's Excel, it's not rocket science, but it allows us to track the use of evidence by disease, by location, and over time, and give that again back to the Ministry of Health, who tracks their own use of evidence. And so those three principles really do help us to be able to apply that in any kind of country or context that might be facing a public health question.
Thanks very much, Simone. And I think that the point, about being ready to use anyone's data is something that I think across the humanitarian sector we can really learn from, because oftentimes we'll do our own needs assessment over and over again, which is often a strain on communities. And there's this feeling that, we can't share the data. It's our data, it's our information, and that whole information is power kind of approach. Like, how did you get everyone to agree to that? No logos, share the data, especially, given what we were talking about with Jorn just before around the European data protection regulations or whatever countries' data protection regulations may be in place. Like, how did you get everyone to come around the table and agree to using others' data? And I'm sorry.
That's a really good question.
Just to add to that, because Gilbert had asked a question around, we've not always been on the same messages, humanitarians and officials, when it comes to messages or fund management, and I guess the data protection as well. So link to that, how do you get everybody around the table?
So I think the first is really, we've never actually had formal, so technically I work for UNICEF. But nobody's writing partnership agreements. We're not making big contracts. We're all doing it because it's the right thing to do, actually. That's the first thing. There's actually been a really organic approach of, if you give yours first, guess what? Everybody kind of comes around the table. And it's been 4 years of this. It's actually worked very, very collaboratively. I think the other thing is also recognizing that everything we do is operating under local Minister of Health and Minister of Health. So we have terms of reference to exist in this IOA way under the Minister of Health. So every kind of analysis or study or tool is developed on kind of a one-page terms of reference. It is signed off by the Minister of Health and it's owned by the Minister of Health. And so now we're working with MOH to say, for example, in the cell this time, everybody signed something to say, actually, this belongs to the Minister of Health. Actually, when we work here, we're not taking data out, we're bringing data in, we're working in service. And so that's something we're working through. But in terms of everybody kind of coming together and collaboratively, I think we do have a willingness when we're saying, like, we see it being used, we see it being useful. And so that is helping, but each one of us being really transparent and that we're here for communities, we're here to support a better response. So focusing on that has been really important.
Thanks very much, Simone. And I think it's great that you've got that willingness, because you see that sharing the data does give you the better sort of response that you can have in terms of managing an outbreak. And I think that's definitely something we can learn from across a lot of different responses, I think, in the humanitarian sector, because we're not always, we're very willing often to share the data, but I think looking at your example is excellent. And it seems that we lost you just, oh, there, you're back. But yeah, thanks so much. No, it was a perfect timing for your connection to drop because you'd finished answering it. But I think really lots of really great lessons for us to learn across the sector from what you're doing there in really sharing the data and having that ownership by the Ministry of Health. Super important. So thanks very much, Simone. I'm going to turn to Umbretta, who, as I mentioned, is the Community Engagement and Accountability Advisor, Senior Advisor in the International Federation of Red Cross and Red Crescent Societies. And Umbretta, we're going to stay with the Congo context, so kind of building on what Simone's just been talking about. Part of your research has been around community feedback. So based on your research, Umbretta, how have you, in terms of using community feedback for decision making, and with the work of the Red Cross in the Congo in community feedback data systems for collective action, how can we and why should community feedback be included in decision making processes during an outbreak response?
Thanks, Maisha, and morning, everybody. So I'm keeping you all again in Congo because there is so much we've learned there. But I'm bringing you to the eastern beautiful part of Congo, North Kivu and Ituri. Let's go back to 2019, where we learned a great deal of things. So the epidemic had started in 2018. It was the second biggest outbreak. We thought that was the biggest challenge we had. Then 2020 came. And back then, aid workers were struggling really to contain the outbreak. Violence was on the increase, vaccines were refused, treatment centers were being attacked, volunteers and health workers were being attacked. It's 2019, and the humanitarian community was calling for a reset in the Ebola and strengthening strategies around bringing community ownership to the forefront. Sounds very familiar with 2020 COVID, right? I mean, this reset of the strategy, let's go back, change things. Back then, and Simone gave a great overview. Back then, we had all the data we needed to really take the action. Those community data Simone was speaking about, we had them. We had 300,000 data points from feedback from communities, unstructured data from communities telling us the questions they had, the concerns they had, the changes they needed for our collective actions. This was data across 29 health zones collected by 800 volunteers on a weekly basis. So every week we would get this data. This data was then cross-analyzed with the data that Simone was talking about. So the research we did was about understanding if this data was used and or not, and why so. And what we found out, and I need to acknowledge the London School here, and unfortunately the colleague could not be with us today, but they helped us understanding what was happening back then. And what we found, first and foremost, what was validated by the research is that the feedback data is an essential form of evidence. It has an instrumental value in the sense that it helps us change gear and shape our response to really respond to the needs on the ground. And it has also an intrinsic value. It promotes social accountability. Is a platform for the local voices to be heard. It does help us in strengthen ownership in the sense that it's about co-creating then the solutions and the responses to the concerns. And it gives us the legitimacy. So why it is important? It gives us the legitimacy to ask for certain changes to happen. What has happened and what we've learned from the research is in this quote that one of the UN leaders said, which is, it takes time because the response is like a big ship. And when you want to turn the rudder, by the time you do and the response shifts, a long time has passed. So what happened is that we had too much data. We had also a hierarchy of data, and the responders had a hard time to make sense of this data. When I say hierarchy of data, it was the responders were primarily epidemiologists, and they were used more quantitative data. So this qualitative data was dismissed most of the times and not used to really change the dynamics. And there was also what was called in the research evidentiary inertia, which means the geographical scale, like in COVID, and we've seen that, the structural barriers and the large numbers of responders resulted in difficulties by the responders in really absorb the data and use the data and make nimble response, fast and agile changes in the response in a meaningful way. And this we've seen, it sounds again familiar with some of what we've seen in COVID. Some of the critical issues and challenges we've seen, again, it goes back to what Simona said. These are community data. So often there was an issue with the branding of the evidence. So everyone wanted to have its own evidence rather than using the evidence that was there. And this came out really clearly. Red Cross was not seen often was seen more as a viewer than as an organization that was bringing evidence to the table. But what we learned there is that this evidence was for the common good, and we made it available for the common good, for the collective action. The value of the evidence, this is qualitative evidence and is often not taken seriously by responders because they are overwhelmed, and sometimes they clearly might not understand the value of it or how this can be used. So Maisha, let's go to the solutions. And I think, this is what matters here, which is around how can we make sure that this is constantly used and included in the way we operate. So what we found in the research, and I'll say a few more examples later, but we need to have really to make a package of tools available to all responders. And again, going back to unbranded, not really attached to one organization or the others, but make sure that we have a standardized way of using this data and have the tools to do so. And this capacity building that Simone talked about as well is not about capacitating local actors only. It's also capacitating local the leaders of the response, for them to understand this data. We need to be able to test different approaches. So it doesn't have to be the feedback system we created in Congo, but it can be a very small scale type of feedback system. And we need really to value this type of data as a source of intelligence across crisis and outbreak response, and ensure that we're able to track the action. This is what has come out clearly from the research.
Super. Thanks very much, Umberta. And I think, you know, there's a couple of questions here in the chat, in the Q&A, sorry, around, and in the chat. I mean, this question really, like, we are talking often about community as just one big thing, but we know that in a community there's all sorts of individuals in there. So and now I'm trying to find the question. I've now lost it. And Mary was asking, you know, in contexts where there's a progressive deep divide between the minorities and a majority in a population, how do you balance community feedback between different groups? And, you know, it may not just be two different groups. You may have different views depending on a variety of contexts, you know, so how do we really take all that information and really kind of distill it into something that leaders can then take decisions around? Or how do you then use that data to be able to change responses? And I guess in that sense also, you know, given that IFRC and the Red Crescent societies are active in public health emergencies and humanitarian crises, you know, what is the investment that you need in data systems that can also help for preparedness and response? And how do you then capture all those variety of views from communities?
On this question, this is great. And I think what we've learned during COVID and we learned in Ebola back then is about localizing the systems. So we've, from the beginning of Ebola to the end, we've really shifted geared and made sure that we took decision closer to where action was happening, which means the data was the format of the data changed in a way that it could be used immediately. So with quantitative way of presenting the data, the decision-making coordination was more localized. So the data was discussing coordination for locally in the health zone where action was happening, which allows us to understand the different views, meaning if there is a minority group in that area, it allows the responder to contextualize things and to really understand the dynamics. And it means also making sure that there is a longer term investment into the capacity on the ground. So creating feedback data systems that are localized means that we need to prepare for it. So it cannot be done during an outbreak response. So that people are used to understand this data and use this data for action.
Super. Thanks very much, Simone. And I guess maybe just link to that, you know, that how you've got those systems, you know, is there something with those investments in the systems, you know, for that preparedness and response? How can that, you know, meaningfully change policy and practice more broadly in the humanitarian system?
Again, I mean, this has to do really with the systemic change that we've been talking for a while in the humanitarian system, which means that we need really a paradigm shift. It needs a shift in the response structures and also in the investments that we do. So if we want to have this embedded into our response, we need to have a different incentive structure. We need to have different power dynamics that are really geared towards localized decision-making and localized coordination systems. So a big ship cannot take the decision in an agile and responsive way. And this is what communities want from us. If we don't take those decisions and changes rapidly, The issue is often with the frontline workers being attacked because communities get really frustrated. So it's not a cosmetic change that we need to do. It's something that can save the lives of frontline workers like the volunteers that are facing the communities.
Super. Thanks very much, Amrita. And last but not least of our panelists, and I know we're coming up, we've only got about 15 minutes left. Ngoni, we're going to turn a little bit now to sort of the work that you're doing in Eastern and Southern Africa with the collective service for risk communication and community engagement. And based on the experience of the collective service in your region, how can social data be meaningfully used to shape the response during epidemics or other humanitarian crises? You're on mute still.
Okay. Cool. Thank you, Manisha. Hello, everyone. I think there are a couple of issues that come into play when we look at how the social science data can be meaningfully used. There is the issue of buy-in from country partners, which is very key. As collective service, our support is demand-driven and therefore tailors the technical support to specific requests which we receive from country partners. So this ensures there is sustainability in the support that we provide and that we are building in terms of capacity around how to generate and use community insights to shape the response efforts. Mostly the requests comes from the RCCE pillar leads, who are usually the Minister of Health. And this helps in ensuring that national governments are at the forefront in terms of championing actions for data insights. Like I can take an example for Zimbabwe, the data that is generated by both the government and partners is being fed into a central government platform, and it informs the national RCCE strategy. So this is something that I realize is also very key. And secondly, using channels and approaches which are already working well for the partners, so that we don't force partners to adopt tools which are sometimes time consuming and expensive. So as collective service, we are collecting the data shared by the partners at regional level and producing joint comment feedback in the infodemic monthly reports. But each partner looks at their own data, and regardless of how it has been collected, when they submit it to the regional level, they submit the top 3 to 5 main trends they have seen in that in the data for that month. This is then coded using the coding frame that is standardized across the whole country, so that the key trends in the feedbacks can be collected, analyzed, and shared for action. So we are trying to establish an interagency mechanism by supporting partners to continue using existing approaches and channels for community feedback, whether they are using hotlines, face-to-face, focus groups, social media, or whatever. And for us, we're just coding the qualitative data that they share so that we can extract the main trends and the themes from the data, and we try also to centralize it in an interactive dashboard for all partners to use. So the data that is collected by the different partners, once is centralized and we produce the dashboards, any partner has got access to that. And it's not only accessible to partners who are within the RCCE technical working group or pillar, but we also make sure that this data is also extended to all the other response pillars, to other sectors, so that they are informed in terms of what is coming from the community. So we bring everyone feedbacks together, whether they bring it online, hotlines, face-to-face, and peer, and we'll try to make sure that decisions are made and all the response clusters, they appreciate what is coming from the communities. Then there's also the issue of ensuring that data feedback is discussed in the right platforms. In ensuring that this data is shared and discussed in the correct platforms. We try to make sure all the coordination meetings outside the RCC technical groups, technical working groups, helps to ensure that all the technical sectors understand that they have got the responsibility to listen to and act on what the communities are saying. I can take the example for the recent KwaZulu-Natal floods response. As a collective service, we supported setting up the community feedback. We learned from the COVID in terms of the capacity that we've built to other countries in terms of setting up community feedbacks for COVID. But we have a special case for the KwaZulu-Natal where we extended the community feedback system into a multi-sectorial approach where the community feedbacks that have been received are now being discussed by WASH, by shelter, by education, by food security, and all the other response actors for action. So we have supported to ensure that the multi-sectorial data that has been collected in part of translating the community feedback into action, we engage all sectors for action. So as we translate feedbacks into action with the communities, we also make sure that relevant government and response partners are part of the action, feedback action meetings. Like from the feedbacks that we receive, we were informed that most of the non-food items that were being given to the people who were in collective centers and those who were in the different displacement modes, they were only mostly for adults. And from the data that we collected, we realized that infants were left out. So we had to urgently reach out through the coordination structures to all the partners and government. And we're definitely happy to say through the feedbacks that we got from the communities, the private sector even came on board in terms of supporting with baby wear, Pampers, and the other wide range of baby foodstuffs. So you can actually see that using data that we get and taking it on the right platforms, we can actually identify the gaps that have been that are available from the feedbacks that we're getting, and agent action can actually be done, especially if we're engaging the correct stakeholders. Then there's also the issue of building capacity at country level, where developing and using interagency training package on the community feedback, which we have rolled out in different countries like Eswatini, South Africa, Zimbabwe, Malawi. This is mainly utilizing different strengths from different partners to bring standardized approaches in collecting and analyzing, and also disseminating and acting on the community feedback and social science data. So if all core partners talk about the importance of community data in the same way, then we help to more systematically generate data to generate like more buy-in from the country level partners for this work. I can take also an example like in the KwaZulu-Natal floods response that we have recently supported. The partners that collects the data is not the same partners that should be responsible for action or making a decision or responding to requests that will have come from the communities. So the data that we generate is not only meant for an organization or for the core partners, but it's data that is relevant for all partners to use, and they can actually make decisions and allocate resources accordingly as and when they see relevant. Thank you very much.
Thanks very much, Ngoni. And I think that point really about like not imposing sort of a system whereby the data has to be collected, but taking whatever partners have in terms of the data often will obviously help, because I think trying to come up with a common system can often be very time consuming and potentially controversial, and can result in a lot of resistance. But like based on the experience where you've got partners working together, they're sharing their data, do you see an appetite in the East and Southern African region from countries to use social data as part of their response practices?
Yes, the type of request, as I said, the collective service, our support is demand driven. So the type of request that we are getting from the countries is very interesting, especially after we introduce the collective service and the menu of service that we have. Most of the partners have requested support on development of data collection tools, analysis, generation of insights from community feedback, data and social science training support. So we have received requests like from countries like Eritrea, Lesotho, Eswatini, Namibia, Malawi, Zimbabwe, to support setting up community feedback mechanisms and to train the teams on social science. So in terms of to align with the collective service support with these requests, we prioritize a detailed context analysis, and we then develop hybrid trainings which cover community feedbacks, digital social listening, social science, M&D frameworks and everything. And we have further developed the guidance documents, which will act as referral points for anyone who will be involved in the response efforts, whether it's within the COVID structure or any other public health emergencies, considering that we have extended our terms of reference beyond COVID to cover any public health emergency. So these have really worked well, as evidenced by the increased in the number of, for example, the collected feedbacks and rich insights from the communities, which will be happy, which is helping to inform the response, considering the evolving context and the new emergencies that will be realized. I can take an example of Malawi. We supported Malawi in terms of capacity building on community feedback mechanism, but they are currently also using the same approach in terms of the ongoing efforts on cholera response, polio, and cyclones. So yes, there's a lot of appetite from the SR region, and it's very encouraging. And as collective service, we are ready to continue supporting building this capacity to be able to respond to all the public health emergencies. And you also realize that the technical working group is also being requested to support coordinating the RCC response in the Horn of Africa at the moment, which is considered one of the worst crises. So there's a lot of appetite from all the countries that are supporting, and even from all the donors that we're engaging with. Thank you.
Thanks very much, Ngoni. And there's a few comments in the chat, and then there's a question for you that I'll ask you in a second. But there's this need for successful integration of community feedback as an indicator of program success, which we don't often see. And maybe that's something that we need to start thinking about when we're talking about program success. There's systemic, Umberto, thanks to all the panelists who've been answering the questions, and Marcus for pasting those responses into the chat, so those who may not have seen them. And there is a question, and I see Umbretta is typing an answer, but I'm still going to ask it to you as well, Ngoni. And then I'm going to maybe turn to all of our speakers for just like a 30-second last word before we wrap up in 5 minutes. So, to what extent can we ensure communities are involved in the mechanism of the collective service when the tools used by humanitarians are designed by experts in air-conditioned offices, far from any community participation? That's a question from Gilbert. What's your response to that, Ngoni?
Okay, thank you. So you realize that when we go to any country or context, we take time before we roll out any community feedback system to appreciate the context, to share with them in terms of how are we going to be collecting the data, and contextualize all the tools so that they are very much relevant. And we include the affected communities in terms of setting up the different platforms. So you realize when we're talking about community feedbacks, it's not like tools, questions, or whatever. We just sit down and listen to communities. That's all we do. Whether they are questions, whether they are suggestions, whether it's sensitive information and everything. So our role is just to record, and then we'll have to code that data depending on the feedbacks that we're getting. So there are no special tools that are developed by the collective service in terms of engaging with the support with the communities. But all that we do is we sit down with them, round table or in a focus group or face to face. Then we'll just be writing what all the responses or the inputs that they're getting, and then using those responses. Then that's when we come up with different coding codes where we can standardize the responses to be able to be analyzed across all the countries. Thank you.
Thanks very much, Ngoni. I'm going to turn to all of you just for like a quick 30-second, last minute takeaway that you want people to remember. I know you've all talked about great examples that you've got in terms of how you're using community feedback, but kind of moving ahead, what is one thing you need or you think that we should be doing better around community feedback moving ahead in terms of accountability? Maybe I'm going to start with, hang on. I'll Gibstar, shall I start with you? And then I'll go Joran, Simone, Ambretta, and then Ngoni. Just 30 seconds, please.
Thank you very much, Manisha. I think the one thing I would like the attendees and the participants to go with is the fact that we really need to accept and recognize the inherent wisdom and appetite to respond to any pandemic that is inherent in the communities that we save or seek to save. And so that will entail our involving them, at least for the key community leaders or players, from the program or pandemic design to implementation to feedback. So that acceptance and recognition of the capacities that are inherent in communities, because they may be cultural, and leverage the three things that communities enjoy, which is a trust of their local members of the community. They also enjoy intricate knowledge of who's who, what is what, and where is what in the community. And finally, access to households, which can be a tool used to encourage social behavior change as an element of that response. So that's what I would like them to go with. Thank you, Manisha.
Thanks very much, Gibstar. Joran, please. 30 seconds.
Yes, I think one of the things that we learned along the way is the strength of having community members being in your program and making every interaction with the community, by them or by your program, a moment for service delivery, but also a moment for education. I've noticed over the year and a half that our population has become very good at assessing transmission risk and knowing who should be cared for in what way in case of COVID. And I think that's an important strength, to bring people in, teach them, and have them spread the knowledge to the population.
Super. Thanks very much, Joran. Simone, one thing we need to be doing more in terms of community feedback in 30 seconds, please, or less.
I think just being really flexible, not having predetermined tools or ideas in our head, but making sure that when we collect any kind of data, be feedback or other, that we are integrating that data with other sources and facilitating access to the data back to communities and decision makers in country.
Wonderful. Thanks so much, Simone. Ambretta, please.
I would say normalize this type of data. So normalize the community feedback system. So normalize means that there needs to be investments into the financial sustainability of these systems, long-term capacity strengthening of the local organizations and of the community health systems that could really be owning this type of data systems. And this needs investments now, not in the next outbreak.
Super. Thanks very much, Ambretta. Last but not least, Ngoni, one key takeaway for us.
Okay. So
You're good.
Okay, thank you. I think the takeaway from my side would be, how can data be used as a coordination tool? Mainly like the use of dashboards to visualize feedbacks. There's a lot of evidence that support that. The broader point that we need to understand how certain decision makers digest the data and how we can ensure that community data is presented in formats which are engaging and compelling. Then it's that is more at strategic level. At sub-national level, we'll be looking at the use of feedback data to determine how resources can be used and prioritized. We have seen also evidence in countries like Zimbabwe where probably the data that is generated has actually been used to support and address needs of specific groups like the apostolic religious acts and the youths. So feedback data is being used by partners to determine how and where resources need to be allocated and meeting the most pressing needs. Thank you.
Thanks very much, Ngoni. And huge thanks to all our panelists, and also to Sylvia at the beginning for talking about the collective service. I think we've really heard today, and I'm going to bring in some of those responses from the Mentimeter. And thanks to those of you who did respond in there, I think really, we've seen a lot of great examples of how you can use community data in order to better respond in a humanitarian crisis. So whether it's from the COVID response, but otherwise in Ebola, but really understanding how you can identify ways of gathering that information, working with communities to be able to gather data, to share messages. And this important point also that came up in the Mentimeter about really needing to close the loop on the feedback that you get from communities, so that because they often have the best solutions, but we need to find ways where we're able to, in our methodology of collecting the data, be able to identify information coming from diverse sources within a community, because as was rightly pointed out in the Menti, communities are not homogenous. They are filled with different individuals of diverse characteristics that may, put them in a more vulnerable situation or in a situation of power. And we really need to be thinking about that. But I think it's also important that, as we're trying to bring all this data together, that point that was raised, and I think the iOS and the collective service, getting rid of the branding, really understanding that the point of sharing data is that we can have better responses, that we're able to use that data from communities to be able to shift our responses and to really adapt programming so that we're better able to serve and meet the needs in a humanitarian crisis. So lots of really important examples that were shared with us today. And I think really identifying ways to overcome this kind of data ownership that we often have is really critical, and putting in place those systems so that we're able to be better prepared to respond when there is an outbreak of a disease like Ebola or COVID. But, really being able to have those systems in place and having that sharing of information in place is really critical as well. So I think, and then also really building the capacity or enhancing the capacity that already exists in the various countries where we work, so that they are able to have those data systems in place later on as well. So huge thanks to everyone on the panel and to everyone in the audience. And I know there was also a comment about, we're starting to get into terminology that's getting more complicated. So for many of us who are not specialists in data or community engagement per se, as Mary pointed out, it's starting to become a little bit unintelligible sometimes around all the different sort of terms that we're using. So I think we also need to kind of keep things quite simple, so it's easy for decision makers to take whatever data is collected to really make those changes necessary. And it came out also in our previous webinar, I've got construction apparently in my apartment outside or somewhere, really trying to make things simple for those who are making decisions, because they're faced with all sorts of data and information. So really trying to distill things in an easy way. Apologies for going over a little bit. We will be able to share sort of what came out of the Menti. In addition, we will have a recording of the event. Before that, there is an evaluation survey we'd love you to fill out. It'll just take you a few minutes. We will post the link in the chat and would love to hear your feedback. Thank you very much, Vaughn. We will have a recording of the event, both in video and audio only podcast format in the coming days, and it's on that event page. We also have the recordings and the resources related to all 4 sessions on accountability to affected populations that we've had over the last 3 weeks under the HNPW banner, and you can find those there. And with that, huge thanks to the ISC for organizing these events on AAP, to all our panelists, to Sylvia, Gibstar, Joran, Simone, Umbretta, and Goni for your great insights and examples that you've shared with us. Thank you also to PHAP and for all the technical support, and to Ellen for the transcripts, and all of you in the audience for sharing your thoughts and asking lots of questions and being engaged. And apologies for being a bit over time, but I think we had great examples to hear from. Thank you very much. I will miss having these AAP events, but I look forward to future discussions on accountability to affected populations moving ahead. And hopefully you have all learned something that you can take forward in your day-to-day work. Thank you all.